So our next speaker is Miguel Rodríguez Molina. He's a physiotherapist from OIFE. He's part of the advisory board of OIFE, and he has been working with skeletal dysplasia and OI for many years. He will be presenting about physical activity in OI, a good natural medicine for pain and health in OI.
Thank you. Hi, hello everybody. I'm Miguel Rodríguez. I work for OIFE and Fundación OIFE in Spain. I'm a physical therapist, and I am a very lucky man because I work with all kinds of people with OI, from children to elder ones, from mild OIs to very severe OIs, or from pink elephants to gray elephants, all kind. Okay. So I want to explain my point of view about physical activity as a good natural medicine for pain and health in OI. This is my disclosure. Here has been told the meaning of pain, but I want to focus a little bit in nociception, like the sensory nervous system process of encoding noxious stimuli. Nociception intense chemical, mechanical, or thermal stimulation of sensory neurons called nociceptor produces a signal that travels along a chain of nerve fibers via the spinal cord to the brain. Pain is a detect and protect mechanism, but problems or diseases in the neurological system can result also in pain, the neuropathic pain. So this is my starting point for work with any patient who is experiencing nociceptive sensations, and since I consider that most of these sensations can be modulated through physiotherapy and physical exercise. So if you hear me talking about pain, I'm referring to this physiological part of pain, the nociception. So let's ask the eternal question: where does nociception in OI come from? Okay, first of all, we have two kinds of patients, patients with acute pain and patients with chronic pain in OI, probably the acute pain related to a recent fracture, recent injury, and chronic pain like a more established pain. It's a multifactorial experience for me, and in OI, those main factors that can cause nociception are not all the time all together, sometimes some of them, sometimes others, sometimes one is the more responsible of the sensation. So understanding the biological origin of this chronic pain is the real challenge. How does the bone acute nociception change to chronic in OI? Okay, repeated fractures, stress fractures, trabecular fractures, non-well-healed fractures, microfractures are very common in OI patients. After 3 months of the acute pain of fractures, if it's not healed, there is a marked increase in the density of sensory nerve fibers in the callus and in the periosteum. The hyperinnervation of the bone at the unhealed fracture site is never observed in normal bone and may contribute to the chronic limping and pain-related behaviors observed in some animals, for example, with non-healed fractures. So as a physiotherapist, I work with human movement as a basic for restoring health. Human body is a perfect machine for movement, for continuous movement. And those diseases that reduce movement and have musculoskeletal or biomechanical consequences have a special need of working on it. And exercise is a great tool because of his demonstrated effects to the human body, to any human body. It improves strength, mobility, coordination, function, physical condition, and also it contributes to reduce nociception by reducing inflammation and bone loads, and reduce pain by secreting the natural happy hormones, very common, and they are free for everybody. Especially dopamine and endorphin, because when we do exercises are the more important, but also, for example, oxytocin or serotonin. Maybe you don't know that 10 seconds hug is going to give you oxytocin, for example. I'm free. So let's talk about those factors that can be causing nociception in pain and problems in the OI. Low bone mineral density, osteopenia, for example, and osteoporosis are very common in most patients with OI, and is probably causing pain. We have strong evidence that the strength exercise and impact training directly improves bone mineral density, but traditionally, OI patients has been told not to do this kind of exercise, as they are perceived as a risk. In my opinion, this is a big mistake. It can be a risk sometimes, but the exercise must be adapted to everyone, is the clue of everything. For example, in an OI patient, a mild OI woman, 35 years old, more than 15 years without fractures. When she came to me in 2020, she didn't do any exercise routines, or she has a sedentary life, and she told me she has fatigue, back pain, hip pain, general pain. That's her densitometry, and in the visual analog scale, he told me the pain was 6 in a scale of 10. So after we make a plan of exercise 2 days per week with load exercise and resistance exercise. And we also want to make some activity that she loves to do. In this case, it was mountain trekking or intense slow walking. Even she can run a little bit, so she tried to do it. Always very adaptive, and the results were an improving of bone mineral density without any other treatment, and especially a reducing in the pain sensation. I want to highlight that doing something that she loves to do, such as trekking, was very important for treatment addition in this case, and I think in every case. Another common factor that can be causing exception is the lack of mobility and the lack of strength, the first consequence of the immobilization. Immobilization is the most common treatment after a fracture or a surgery, but I have to ask, is it a necessary evil? Okay, because it's the worst enemy for tissue normalization. And it can induce to joint adhesions, and if rehabilitation does not start as soon as possible, it's a more common problem in OI. I see a lot of adults with OI with these problems. This affects in decreasing range of motion or strength, and the sequels can influence a lot in pain and quality of life in OI. Joint immobilization decreases mechanotransductive signaling and completely inhibits heteropic ossification. Joint immobilization decreases collagen alignment and increases adipogenesis. Joint immobilization reduces bone mass. Moving a joint with those sequels can be very painful, and patients can answer in a very protective way, increasing pain, not helping in the rehabilitation, and not helping in the pain normalization. This is not an OI case, but yes, a bone dysplasia case with bone fragility. It can illustrate that. In this patient, the problem was that after his elbow surgery, he has a long period of immobilization, and when he started the rehabilitation, it was very late and very painful. The joint movement was very painful for him, and he experienced it with a lot of fear. Even trying to explain him very well the need of movement and trying to modulate pain, it was impossible because of the pain. So finally, he has another surgery to solve the joint adhesion problems, and this is need for him because he's a wheelchair user. Now he's starting the rehabilitation immediately after the surgery, just to recover the mobility and the strength. This should be what in the first time he needed. Hyperlaxity, other factor. Extreme hyperlaxity results in joint deformation and alteration of the normal use and normal rounds of joints. And I think that abnormal joint movements can be painful and can stress other parts of lower limbs of body area. In this situation, for example, in this patient, you can see the extreme hyperlaxity and this kind of gait with this kind of standing in the feet. Okay. So after working with him, trying to explain him which muscles are more useful to make a good gait, and after some days of working, he can modify the situation and he can improve the standing. So we plan to work on it, to continue working on it, to trying to improve the gait, and so we designed a plan, and this plan consisted on training an adaptive normal gait for him, and strengthening legs a lot, improving movements, working in proprioception, and using therefore braces in current life. So finally, treatment reduces pain and improves functionality, and now he's a very occasional wheelchair user. Bad alignment of the axis of bones is other factor. In patients with potential possibility of walking, a bad alignment of the lower axis of bone can have a lot of consequences. Obviously, functional consequences in gait are the more common, but painful consequences as a result of this bad alignment, like wrong load supports, non-symmetric lower limbs, muscle fatigue and pain, can also be a strong influence in patients' functional possibilities in long term. Bad alignment can result in stressful movement and pains and reduces global strength in the lower limbs that receive less load or no load. For example, in this patient, a 10-year-old male from Morocco, he hadn't received any treatment until he came to us. He's a wheelchair user, impossible standing, and he had femur and tibia deformities and bad alignment, with a severe muscle shortening in some muscle groups, flexor groups, due to 10 years of sitting position. So the lack of movement made the movement in knee was very painful. So after a very good surgery, we are working in a good alignment, trying to reduce also the muscle shortening, something that is very, very difficult because 10 years of this position, improving range of motion, improving strength, and it has also a deep impact in reducing fears and reducing nociception. He feels more correctly the load of his own body, he feels more confidence, and now we are working in the standing. Standing without pain, but with a lot of effort. Lot of effort. You can see how his flexor muscles are very tight yet, so we are in a progressive loading and progressive tolerance. Early degeneration, or early arthrosis, as a result of biomechanical consequences of OI, so their factor, the degeneration of facet joints due to the own condition of the eye, can be a big problem, causing a lot of pain and decreasing of the limb function. There is no specific scientific literature about that problem in osteogenesis imperfecta. But for me, it's a clinical evidence. Adults with 20, 30, 40 years with hip or knee arthrosis, adults with intramedullary eroding with rotation of the upper femur, adults with very asymmetric loading bones. Which are the best solution? Physiotherapy and exercise here is a little bit limited by the pain. So prostheses probably are a good solution for some adults, and we are seeing a lot. And the good results after the surgery obviously also depends on the good rehabilitation and the exercise. The bone deformities, other factors are common in most severe types. Sometimes they can be a risk, so a good analysis is required before doing any kind of exercise. The main interesting thing is to evaluate the function of the limbs, the quality of the bone, and the possibilities of training, and the pain, of course. In this case, a 46-year-old woman with severe type 3 OI, wheelchair user. She has non-union in both femur, bone deformity in leaves, spine, and upper extremity. She can stand, and even she can do a strange, weak gait. And she wanted to do exercise. This was the most important thing. So we started with the plan. And then with some very adaptive exercise, she's making some loading, working proprioception, or just strengthening arms, for example. I believe a lot in possibilities of people with OI. I think they can do a lot more things that they are used to. I'm finishing. Sorry, I have problems. And finally, the unlucky consequences of some surgeries sometimes, or some problems. For example, this woman, 16 years old woman, with severe OI, severe scoliosis with functional and pulmonary consequences. She had the spine rolling surgery at 12 with a good correction of the curve. The problem is that the lumbar spine continues deforming, and she had intense back pain due to the body position. The right lumbar part of the back is a very painful area for her. Not only muscle overload, even the rib cage rubs against the iliac crest. The fusion part of the back is permanently stick, moving or stretching the spine, difficulties the flexibility needed to relax and stretch muscles. Back active and passive movement are very limited by the condition. Reducing nociception is very difficult in this case because we need those movements. So we need to keep trying it because we cannot remove it. So conclusions, physical exercise is one of the best tools to modulate nociception in OI. Physical exercise is a good natural medicine for pain in OI. must be always planned and adapted to each type of OI patient and for his or her possibilities. Physical exercise must be very progressive and adaptive to every moment and situation. Physical exercise must not be felt as harming, scaring, or painful, and must be a motivation to generate adhesion and must have realistic goal. Thank you. Just for finishing, you can guess here in this video who is the girl with OI type 3 severe, playing tennis with his twin brother and being very happy about that. Thank you so much.
Thank you, Miguel, for these beautiful presentations, all these cases. I think we have like one short question with a short answer.
I can just make a comment. I would like to change to functional medicine. It's more like functional than natural medicine. Do you get me?
Yeah.
Yes, because it's the function we are working with. So it's a functional medicine. Sometimes when we talk with doctors about natural medicines, we don't get the response that we want. But when you talk about functional medicine, it's more like we are working with the function of the body. So I think it's a good way to just change that word.
Thank you.